Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, it's a pleasure to have Shirisha back give another talk for us. I think you guys all know Shirisha. She's assistant director of our Madison clinic here and is going to talk to us today about an exciting new project in the clinic.
Yeah, so thank you, Brian, for actually thinking about presenting this. Lindley, who's actually here, who's one of our infectious disease fellows, Lindley Barbie, this is sort of her project that she's really shepherded through the clinic, and I think it's actually going quite well. And I wanted to talk about the self-testing program in our clinic in the context of screening in general for STDs among HIV-positive MSM. So we'll talk a little bit about the rationale for screening, STD screening, and then go into some specifics about a patient and provider survey that Lindley and I conducted in the clinic, in the Madison clinic, to get at what may be some of the barriers to testing, and then the intervention that we've done so far, and then talk a little bit about doing a brief risk assessment in your own clinic to target our STD testing efforts. So first, I don't think this is a surprise to most of you that MSM who attend STD clinics do have STDs. What is interesting, though, is that amongst HIV-positive MSM, there is actually a much higher incidence of STDs all across the board, primary and secondary syphilis, gonorrhea at all the sites, as well as chlamydia, all much more common in HIV-infected men than in non-HIV-infected MSM. And so this is a study that was done in 4 different cities in HIV primary care settings, and looking at the prevalence of STDs amongst that population, as well as the incident rate of STDs. And we know that they're pretty common. So 13% of the MSM patients in these clinics had an STD in enrollment. All of them were asymptomatic. And then 9%, when you checked at 6 months, had an incident STD diagnosis, so whether that be rectal chlamydia or pharyngeal gonorrhea. And then, so essentially 20% of all MSM were diagnosed with an STD by 6 months, so huge rates of STDs. And the risk behaviors that are associated with these STDs are polysubstance abuse, having multiple partners, so greater than 4 partners in 6 months, and then unprotected anal insertive intercourse. And really that sort of the behaviors did not really change. And that was one of the striking things about this study, that even when they're in care, that these behaviors did not change. And even with the diagnosis of STDs, these behaviors did not change. These are data from King County and the syphilis outbreak that we've had, and the numbers of cases of syphilis that we've seen, predominantly in MSM. And these are data that go up to 2011, and we see that it's probably coming down more recently, right? A little bit, maybe, Lindley, maybe not.
Not in 2012.
So we see that there's just a huge upswing in the number of syphilis diagnoses, and you can see that amongst all MSM is in the blue, and then HIV-positive MSM in the purplish color, and you can see that most of the syphilis diagnoses are in HIV-infected MSM, and there's a huge percentage that we've seen that are diagnosed with syphilis and HIV at the same time. So their presenting symptom or complaint is syphilis, or even asymptomatic syphilis, and they're coincidentally diagnosed with HIV at that time. So we've had a number of new patients enroll in our clinic who were diagnosed with both of them at the same time. So the screening guidelines came out in late 2010 from the CDC, and really encourage, obviously, testing at all sites that are may have an STD. So you really have to ask your patients about what kind of sex they're having. And so urethral NAT is approved, and for gonorrhea and chlamydia, we know that. And then Rectal nucleic acid testing is also acceptable for gonorrhea and chlamydia if they've had receptive intercourse, and then pharyngeal NAT for gonorrhea if there's oral sex, and of course a syphilis serology. And that I know Julie Dombrowski gave a syphilis talk about sort of the ins and outs of what different types of tests are available, so I won't go through that. If they're high risk, testing every 3 to 6 months is really what's key. And one of the issues that we've come about in clinic is that people are actually doing pretty well and they don't need a visit every 3 months, right? And so what do we do if they're still high risk? They're not getting tested as frequently if their HIV issues are quite stable. So what constitutes high risk MSM is multiple partners, so greater than 10 in the last year, or anonymous partners if they're meeting their partners at bathhouses or online. So really important to ask these questions to your patients about what kind of partners they have and where they're meeting them. Stimulant use is a really big risk factor as well, associated with increased risk of STDs. Of course, if you've had a recent STD, you are considered high risk, and then unprotected anal intercourse as well. So STD screening of MSM and HIV clinics. So we'd all think, okay, well, this is a no-brainer. Everybody should be screened. The guidelines say so. We see a lot of high-risk individuals. Clearly, if 20% of our MSM in HIV clinics are testing for an STD, but we're not. Syphilis testing, interestingly, it actually does well, so up to 75%. These are a number of clinics that were looked at throughout the country. And that probably is because it's a checkbox on our lab slip, just like a viral load or CD4 count. There's not any kind of invasive or something that would be perceived as invasive that you have to do. Urethral, so this is a gonorrhea for gonorrhea and syphilis. It's pretty low still, and you can just tell the patient, here's a cup, go, and it's still pretty low. And then obviously for rectal swabs and for pharyngeal, we're seeing even much, much lower rates of testing. So what are the barriers? Well, not everybody has availability of nucleic acid testing for non-urethral sites. So at our site, for instance, it's approved, the laboratory has validated it, but not everywhere is that a possibility. So you have to do culture-based methods, which are not as sensitive and take longer to get the results. Lack of time during a visit. So we all talk about these really difficult echo cases where you're trying to deal with multiple social issues, chaotic life, non-adherence to medications, and then kind of when do you have time to talk about STDs? And then, sometimes it's a provider issue where there's not really comfort in talking about sex and sexual history. And obviously that's something that would be important to overcome in our line of work. So these are some results from the patient survey of MSM in our clinic, and we did it over about 2 to 3 week period, and there were about 110 responses. So about 10% or so of the MSM in our clinic. And so when we asked them what kind of sex they had, so 68% said they were top, so the insertive partner, 69% say they were, obviously these are not mutually exclusive, they could have checked more than one box, that they were bottom, so the receptive partner, 79% gave oral sex, 75% received oral sex. So a lot of sex going on. And then in the 2 months prior, there was an average of about 2 partners, sexual partners. And greater than 25% of the men surveyed had reported a bacterial STD in the past year. And 16% or so report that they or their partners use stimulants. So all getting at high risk factors here. So looking at it some more, of when you ask them were they screened at their last visit, of those who reported an exposure, oral exposure, only 58% reported they'd been screened at the throat, and those who reported they were the receptive partner, only about half had reported they were screened in the rectum. Most patients received their STD care at the Madison Clinic. but some I'll talk about received it in the community as well. And the majority of patients felt like their providers were talking about sex with them, but 17% said they were not. So when they didn't seek STD testing at the Madison Clinic, they went to the public health clinic or another community center for gay men's health called Gay City, where they received STD testing. And when asked why they went, they thought it would be easier, anonymity. They wanted more frequent screening, so that gets to the point, well, I'm only seeing my doctor every 6 months, but I want to be tested every 2 to 3 months. And then cost was also a factor. We also surveyed the providers, and the majority of the providers completed the survey, and 15% of them were actually unaware that nucleic acid testing was available for extragenital sites. And the providers said that the challenges were not enough time, which is understandable. There's a lot of competing issues like we talked about. Patient reluctance, so patients saying, well, no, I don't want to be swabbed, or I don't think I'm at risk. And then a third of people were sort of unsure about the guidelines. And this survey was done last year, so the guidelines had been out for about a year when this survey was done. And then 21% didn't feel comfortable discussing sexual practices or performing a genital exam. So that's a surprising result in our clinic, which is predominantly MSM patients, and I'm sure that's the case in where you're working too, in providing care to HIV-infected individuals. So when asked what kind of interventions would help, having the results from other testing sites like the STD clinic, having some sort of way that we could remind and prompt providers to know when STD testing is due. And then over half of people were interested in getting self-collected specimens. So when a patient comes in, they can just get a kit, or they can go in the bathroom and then swab themselves. And then also about half of providers wanted a brief educational session, which actually Lindley gave and did a wonderful overview of the STD screening guidelines and some of the results of these surveys. So the intervention that was implemented is the self-testing program, and we have posters in the clinic that get at this, but basically we allow patients to just walk in and say, I want to test myself. They get a quick screening, 3-question screen by the nurse, basically to assess whether they're actively symptomatic, because if they're symptomatic, then they need an assessment by a provider. But if they're completely asymptomatic, they can go ahead and screen themselves. I want to make the point that this doesn't preclude genital exam by the provider, which may be a tempting out to say that, but no, we still need to do genital exams for other reasons, for anal health screening. For some places in our network may be doing anal PAPs for anal cancer screening. We're not at our clinic, but we do encourage anoscopy for high-risk MSM, and particularly who've had a history of HPV warts, to do that. So this does not obviate the need for actually looking at your patients, but this is to enhance their ability to get STD testing. So one of the ways that they can do that is just walk in. Another thing is that a provider can say, you're due for testing, go ahead and go in the bathroom and do the swabbing yourself. And then another way is that we actually have a self-assessment that people fill out that's done every 6 months. And if they have, if it says that they're sexually active and have risk factors, to go ahead and prompt testing that way. Like I mentioned, nurse triage ensures that they're asymptomatic. And then if they're asymptomatic, they're given a screening form, which is actually a useful tool for us, for Lindley and I, to look at when we're evaluating this process, that asks the patient what are the sites that they have sex, and then it says, if you give oral sex, well, then you need to do the swab at this. If you have oral sex, rectal sex, then you need to be doing the appropriate swabs, essentially. So this is a poster that we were fortunate to have a medical illustrator do for us, which is actually really nice. And these posters are huge in our bathroom. You cannot miss them. And as the providers who work at our clinic know. And it really just walks through the steps of how to obtain your own throat swab for nucleic acid testing. All the labels are there that are pre-printed that say throat or rectal. That the patients can just slap on there along with their label, which is given to them by the nurse, and then they just put it in a bag. There's also a survey that we have them complete about how the process went for them so that we can evaluate it further. This is the rectal swab. Again, it's easy to follow, and it shows the patients exactly what to do, starting from washing your hands to labeling to inserting the swab, and etc. So one thing I did want to point out is that we have these materials available if people are interested in implementing a self-testing program in their clinics and any of the network clinics. And this is created with funding from the Seattle STD prevention training, CDC Prevention Training Center. And this is all through funds by the CDC. And one of the goals is actually to disseminate some of this material in hopes that we do improve STD testing and get rid of some of those barriers that we may have at our clinics or provider barriers. So in the interest of time, I'm not going to go through all of this. This is just really basic stuff that I think I've talked about before, which is really just talk to your patients about sex. And the more you do it, and for the trainees that are here, the more you do it, the more comfortable you are, the more that your patients will feel that you're comfortable talking about it. So practice talking about sex. And that's really the main thing that I wanted to say. Also, open style questions are way better than saying something like, you use condoms, right? Because that's such a leading question. Instead, how do you protect yourself would be a better way to do it. So there are ways that you can get your patients to open up and talk a little bit more about their sexual practices. So that's really all I wanted to talk about, and I'll just end with this slide.